Hey everybody, Dr. Tassone here. Just doing a Facebook Live, and I thought today we'd try to do some Q&A on any questions or comments that you might have regarding Essure Removal. I would say in the last 6 months, I've noticed quite an uptick in other providers that are doing the procedure, and I just wanted to be able to not give medical advice. Obviously, you need to see your doctor, but I wanted to be able to talk to you about the possibility of having the coils removed and the tubes versus hysterectomy, or any other questions you might have on ablation or laparoscopy, Da Vinci, whatever questions you might have about the process that might better equip your fellow ladies that need this removed or want this removed. I noticed that as we have people coming on, if you would go ahead and type in your questions in the comment section, I can put them up on the screen here and everybody can see your questions. So if you have questions about Essure Removal, preoperative diagnosis, what involves with the initial visit, at least at my office, I can speak to what we see, what I've been seeing, issues. I will tell you, if I don't get many comments, that we can do something where I'm going to go ahead and put in right now a link to my scheduling website, where if you do have a question and you want to come see me for an Essure evaluation, you can go to www.aaobgyn.com. The very first page on there is how to schedule an appointment, and it will basically let you do it online. It shows you my available appointments, and as I said before, I kind of keep you guys in the know. So go ahead and start shooting me any questions you might have about Essure Removal. What I'm going to do is kind of talk about what I think should be done. Obviously, this is the way I do it. I'm not saying this is the way, but I've probably been involved with about 250 cases over the last 2 years that I have removed, and I'm seeing some other cases now. Rebecca, says, wish the procedure that removes the tubes and coils, what is the recovery time? So with that question, the recovery time depends on you as a person, and it could be anywhere from 1 to 6 weeks. Usually just having the coils and tubes removed, if you don't have a labor intensive job, you're probably looking at, 1 to 2 weeks until you can go back to your job. Yes, a lot of us will be traveling several hours to see you. Can you tell us about how many visits it takes from consultation? So what we do is we usually see you, Joni, for the first visit. I do an ultrasound. I do a pelvic exam. We map out the pain. We talk about what your symptoms are. And then I also draw hormone levels, and I send you for an x-ray so I can locate the coils. At that point, I'll send your chart to Leslie King, who is on my team. And Leslie will get you started talking to you the insurance. She'll get the benefits going, and then she's going to give you a call, and she's going to tell you if there's a copay, and she's going to schedule your date. So then you would come in the day before the surgery. I operate on Thursdays, so you would come in on Wednesday afternoon. We would do the pre-op at the office. We do the pre-op at the hospital, get your blood drawn, and then we would go ahead and do the surgery the next day. For those of you out of town, I probably keep you overnight, and then we send you home the following day. So you're looking at 2 visits up to that point, and then a post-op visit at about 4 weeks. Jessica says, how would you do a surgery for people who have high blood pressure and have to take blood pressure medication? Jessica, that's usually not a problem. You usually just take your blood pressure medications up till the morning of the surgery. As long as your pressures aren't like critically high or something abnormal like that, that's not a problem doing your surgery at all. And it's something that I do all the time. So this is an interesting concept, this coils question, because what I think you mean by my wife has 3 coils on the right and 2 on the left, that probably means that when they did the procedure and they put the Essure in to the actual tube, forgive my graphics here, there were actually 2 turns of the coil that were sticking out on the inside, and then on the other side they were having 3 coils that were sticking out. That doesn't mean there were 2 actual coils on one side and 3 coils on the other side, and that I could determine at the x-ray. But usually people get confused by that, and what that means is that there were 2 spins of the coil that were coming out of the tube on one side and 3 on the other side. Nicole, so should we plan on staying at least 5 days in Austin if we're from out of town? Most people, and I think you could ask the ladies on the website, we basically would make sure that, you need as much time as possible. But usually that initial visit, I have some people come in just for the visit. They get the evaluation. They go home that same day. And then they stay overnight for the surgery and they go home on Friday. So usually it's not a very long stay. Joni, I was recently diagnosed as having a TIA and blood thinners. Being on the blood thinners is an issue. Obviously, you're going to have a potential for more bleeding. But with surgeries, we would have you talk to anesthesia. We would have you see your internal medicine doctor or whoever is treating you for the blood thinners. Tell them that we're going to do surgery. And usually we have you stop those probably 24 hours before the case. And then we start you back up after the case. Jessica's husband's back. She actually has 5 coils in her pelvis. Then we get all 5 of them out. And when we do the surgery, we do an x-ray to make sure they're all out of there. Unfortunately, I've seen 7, and yeah, we get them all out. So that's what we're going to do. We're going to get them all out of her. Christina, what is the best way to normalize hormones after hysterectomy leaving the ovaries? Everybody's a little different. Christina, my fellow English bulldog lover. What I do and what I tend to do is I'm more about balance than telling you that they're normal, because everybody's different. Normal is different. Even in life in general, right? What's your normal, I might think is, crazy or hectic or whatever, and vice versa. So I try to get everybody back into a balance, and then I base it also on how they feel. So I get hormone levels and I tinker with doses until we get it right for you. Nicole, do I need a pelvic x-ray done before I see you? I'll do the x-ray the day that you come see me. Thank you. I'll see what I can do about getting her down there, but she just started a new job. And you can tell the job, look, she's got this medical issue, and if you want her here and you want her here to the best of her abilities, then we need to get her in tip-top shape so that she can do that. And I think that's perfectly legitimate. So 2 things that I always tell patients, and you've probably seen me, and I'm being a dead horse here, I'm a broken record. 1, ask your surgeon if they're just going to do coils and tubes. How many have you done? And I'm not trying to be an elitist. Obviously, I had to learn somewhere. But you're probably not going to get really good at doing just the coils until you've done about 20. So if you have somebody that you're their first case or their second case or their third case, it's up to you. I would probably go somewhere with somebody that has more experience if you're just doing coils, because they break and you don't want to be left with fragments. The second thing that I tell people to ask is, how do you do it? So it's one thing to know how many they've done, but you want to know how they do them, because they can tell you, oh, I'm good at it, or, oh, I've done it, but you really don't know unless you know how they're going to do it. So what you want to know is, how are you going to do it? Have them draw you a picture. So if this is the uterus, I'm going backwards, and this is the tube, you want to make sure they're doing a procedure where they're not cutting the tube off right here at the uterus and then just saying they took your tubes off, because there's still a portion that might be inside the uterus here, okay? And that's going to be left behind. And I see that all the time. I see pieces left inside the uterus. I see pieces left in the tubes. You want to ask them how they're going to do it. And anything short of cutting a hole into the uterus where you're going to core inside of it, and I call it a coring salpingectomy. Dr. Daron calls it a salpingectomy en bloc. Eric Sills does it. I don't know what he calls it, but it's all pretty much the same thing. I call it a coring salpingectomy, where I actually core into the uterus to remove this all in one piece and take it out. You don't want anybody that's going to cut the tube and then pull the coil out. You don't want anybody that's going to just cut the tube or shear it off at the uterus, because you could potentially be left with pieces. And as Deborah Logan just said, that happened with her. And I'll tell you what, Deborah, it's happening all the time. I can't tell you how many women are now having coils removed because more and more doctors, it used to be about a year and a half ago, nobody was willing to even talk about it. Now what's happening is there's a lot of women out there that are having these things removed because the doctors are telling women they know how to do a self-injectomy, which is true. They do. All of us know how to do a self-injectomy. It's an easy, straightforward 15-minute procedure. But when you put the coils in those tubes, it's a heck of a lot different. And so it really is going to depend on, what type of surgery and what, the surgeon that's doing it. Rebecca just asked, is this done with robotic? I do it with robotic because the robotic surgery, in my hands at least, gives me a much better tactile element where I can articulate the pieces of the instrument, so I can have a more finesse approach to getting those tubes out intact. If you have a doctor who is what we call straight sticks, meaning they're just using regular laparoscopic equipment, that can certainly be done as well. But I know Sills does does Da Vinci. I know Daron does Da Vinci. Julio Novoa, I think, is a straight stick kind of guy. So I would, as long as the surgeon is comfortable with their technique, I think that's what matters the most. So what's involved with a proper workup? And I think Penny from the main page would agree with this. The number one thing is, where are the coils? It's important for everybody, not just patients that are having tubes and coils. It's important for everybody to know where the coils are. An x-ray will tell you where they are. It won't tell you the grade, but it will tell you where they are in the sense of they're in your pelvis or they're up by the stomach. An HSG, which I know Dr. Sills orders before he does his removals, will tell you the grade of the coils, meaning are they partially in the tube and mostly in the uterus? Are they half and half, or are they completely in the tube? And that's pertinent if you are having, that's why I do all mine as a coring self-injectomy, because my theory is, even if the coil is in the right place, or even if it's a grade 3 and it goes completely out into the tube, as it's being inserted, it's dragging PET fibers through that mucosa and through that tubal epithelium. So I think we should just remove the tube, and we should remove the whole track of the tube. That's just my opinion. I'm sure everybody's got their own opinions, but that's how I would do it. And so I do everybody as a self-injectomy, a coring self-injectomy, or a surgery, a self-injectomy en bloc, as Dr. Daron would call it. We've got, I had only one coil placed on the right tube. Is there an option to become pregnant after removal? So if you have the tubes, there's two, this is something that gets confused as well. There's reversal and there's removal. I only do removals. Removal is where I remove the tube with a tiny piece of the uterus still attached, as I talked about, and then I sew the corner of the uterus closed. That technically, you shouldn't get pregnant with that. Now, you can still get pregnant, but you would need to have in vitro fertilization, test tube baby. You need to go see a reproductive endocrinologist, somebody like Eric Sills, who does, IVF in the area where you live, and you could still get pregnant. If you have a reversal, which is what Monteith does in North Carolina, where he removes the coil and the part of the damaged tube and then reattaches the tube to the uterus, that's called a reversal. That's about $6,000–7,000. And Monteith and I, have discussed this online a few times, and I know Sills doesn't do them. And I agree with Eric on this, that I don't think the success rates are high enough to warrant the price, but I know Monteith would argue that, and he has data. So if you're interested in that, I would definitely ask him. But with the surgery that I do for removals, the point is, you had these done in the beginning because you didn't want to get pregnant, and I take them out and I take the tubes off completely, which means you won't be able to get pregnant again. So what does my workup involve? You come to the office and I do a pelvic ultrasound. Sometimes we can see those coils, and we'll be able to check those out, look at the lining of the uterus, look at the ovaries, make sure there's no big cysts. I do a pelvic exam to see where the pain is. If you're having excessive amounts of bleeding, we might do an endometrial biopsy. I do hormones on everybody because about 95% of y'all are seriously estrogen dominant. And that can make you feel like garbage as well. So I try to fix that before we're even doing the surgery. And then I send you down the street a couple miles and we get the x-ray done. How much does it cost for removal? If we're talking about removal where I just take the coils out, that's usually covered by insurance. Obviously, prone to your deductible and any other copays you might have, but we run that through your insurance. Nicole, if there's large cysts, I take those out at the same time. I mean, we do as much as we can at the same time. It depends on how big the cyst is. Many times we can just remove the cyst and leave the ovary intact. We don't have to do anything special. I think, it's a great way to do things. I mean, obviously, if there's endometriosis, scar tissue, cysts, we fix all that at the same time. It's not just a one-stop shop. I mean, I'm not just focused on the tubes. We'll fix whatever's going on in there and get it done for you. Anybody else have any questions? We are at my office. Obviously, you all have spoken to Amber. She's my nurse. There's also Angela, who actually is a nurse for Dr. Lander, my wife, but she also covers the phones and schedules appointments. So if you get Amber or Angela, they'll be able to help you. What you're seeing here is a comment by Dr. Jerry Bailey. If you're ever in the Coeur d'Alene, Idaho area, and you need an awesome healthcare professional, Dr. Bailey is literally the man, and his wife, Pam Legenfelder, is the woman. So if any of you live in Idaho, I would definitely make the trip out to see those guys. Thanks for coming, Jerry. Appreciate it. So what else? What other questions do y'all have? Because I know there's 23 people here live, and who knows how many people are going to watch this afterwards. So, give me some questions that you think might be beneficial to the group. I'm going to try and think of things. I have people coming now from out of state, which is, really humbling. And I'd love to help as many people as I can. And I thank you for that. Jessica, so me bleeding for almost 3 years light and heavy every day is a bad thing. Well, it's bad because it can make you anemic and it's not normal. So even if you didn't have Essure, that needs to be evaluated. And I would definitely go in and have somebody work that up for you. I mean, that's, hormones, organic issues such as endometrial lining, fibroids, other things that could be causing that you need to probably have evaluated. Nicole is lucky enough to have an appointment on the 20th. So, I mean, how much better could you be, Nicole, right? At 2:15, how are we going to do it? Well, I just talked about what we're going to do. We're going to go through everything I just mentioned. Everybody, Tina Linsalata is my surgical assist. She's a nurse. She's from Brooklyn, I think, if I remember correctly. She sounds like she's from Brooklyn. She's a badass, and she's there. You'll get to meet everything for her as well, and she'll come talk to you before the case. Nicole, just the consultation. Yeah, we just do the consultation that day. We do the hormones, we do the ultrasound, we do the x-ray. And then I usually have the hormones and the x-ray results the day after, and we'll get you all scheduled for surgery. Do you need a specialist if the coil has migrated somewhere outside the reproductive organs? That's a good question, Deborah. It depends. I have seen cases where it's up by the stomach in the omentum. I've seen cases where it's gone through the back of the uterus and it's actually touching the colon. I've seen it next to the appendix. If you have a scenario where you need to have a general surgeon there, like if you're worried that it's either inside of a blood vessel or you need a vascular surgeon, or if it is inserted into the colon, which I've only seen one case, and that wasn't actually mine, that was a case I reviewed. You're going to need a general surgeon there for that. But I would say of the 250 that I've done, I've needed a general surgeon one time. So it's pretty rare that you would actually need somebody like that. And Christina just told Nicole it'll be okay, because it will. We're going to take care of you. So what else? We got 26 people still hanging out. There's got to be more questions. Post-op question. 4 weeks, usually for your out-of-towners. If you're in town and you have the luxury of coming in a little bit more, we'd like to see it 2 and 6 weeks post-op. But out-of-towners, it's usually 4 weeks. I'll be coming in from New York. I'm from the Berkshires in New England myself, so thanks for coming all that way. How long should I expect to be in Austin? I've had the workup test done with the doctor here, and if I review your chart and I think the labs are recent enough, along with the X-ray, then what we're going to do when you come in is we'll do the ultrasound, we'll do the pelvic exam, we'll talk about the case, we'll do the case, and then if we do it on a Thursday, I'm usually pretty good with you probably going home on Monday if you feel up for it. And you should be able to fly and do fine, and you'll know by Monday that you're doing okay. And if for some odd reason this hasn't been an issue, but if for some reason you needed to stay and you needed to cancel your plane tickets, I'm sure we could get a doctor's note to, do a hardship on the airlines. But I have not seen that. So the consultation is in person. Yeah, the consultation's in person. So ablation is not contraindicated in my eyes. Well, it's not just my eyes. It's pretty much every OBGYN's eyes. Would you actually perform one on an Essure patient for heavy bleeding and pelvic pain? Well, that's a good question, and I'm not going to lie. I have done that in the past. You don't do them at the same time necessarily, but to do an ablation months later after you've had your HSG is not contraindicated. And it is something that can be done. And if your doctor thinks it's the right thing to do and you agree and you trust your doctor, then I would be comfortable doing that. But I have done them in the past, but I probably haven't done one with an Essure in over 5-6 years. How long does it take for your hormones to balance and hot flashes to stop after surgery with only ovaries left? Well, technically your ovaries, if they work normally, you may not experience any menopausal symptoms at all after the surgery. You may be completely fine. Some women will have a little dip for about a couple of weeks and then things normalize. So it's really, dependent on the person, but overall, I think women do just fine that have their ovaries intact. And if you're not feeling well in a week or two, you can give us a call and we'll make you feel better. Can you explain estrogen dominant and what to do if you are? Estrogen dominance means you have way too much estrogen and you don't have enough progesterone. So your progesterone is way down here, or your progesterone is normal and your estrogen is even that much higher. And estrogen dominance can be in women that are overweight, women that are taking hormones. We have, some phytoestrogens that we can eat. We have estrogens in our food supply from our meat. We have plastics. There's a whole bunch of reasons. PCOS. There's a whole bunch of reasons we can take. We can be estrogen dominant. Well, not me personally. Well, I can be estrogen dominant, but I'm not. I hope. But if you all are estrogen dominant, then what we usually do initially is to give you progesterone to balance out your estrogen, and we can put you on a supplement you can buy over the counter called DIM. Some of you are on DIM because you've been severely estrogen dominant, and that's something we can talk about. Let's see. I'm going to let Tina remind the patients to keep the steri strips on post-op. So Tina is the one that puts the steri strips on. So obviously she's kind of going to be a hard ass on keeping them on. So we get questions sometimes about we put Band-Aids and we put steri strips on. So the steri strips are on the skin and then the Band-Aids are over the steri strips. You can take the Band-Aids off whenever you want because you got the steri strips on underneath those. And the steri strips, I would, like Tina said, probably take those off after about a week if they haven't fallen off or they get kind of grungy and they look gross. Do you recommend at least leaving one ovary, or some women say, why chance it and just take everyone out? I am biased on ovaries because my mom died of ovarian cancer when she was 56. But I would say this, if you're in your 30s, I think leaving your ovaries is probably the best thing to do. If you're in your 40s, it's obviously a personal choice. There's a 1 in 70 chance over your lifetime of getting ovarian cancer, unless you have a significant history of breast, colon, or ovarian cancers, then it's probably a little bit higher. You also have a 5% chance during your lifetime, if you leave your ovaries in, of needing surgery at another point in time for you have a cyst or you have pain or something along those lines. So it's not a significant risk. It's 1.5% of getting ovarian cancer. Your ovaries work until you're about 51. So if they're working, I would say a majority of women keep them in. That seems to be the trend right now. And there's absolutely nothing wrong with that. There's no reason to take them out. It's more of a personal choice. Is there anything I can take to take the edge off menopause without actual hormones? I'm 24 and was thrown into menopause thanks to Essure caused me to lose all my fertility. Well, that is a bummer. I will tell you that. There is a product out there called Feminescence I recommend. I don't think this little comment thing is working. Did that just come out? Did Feminescence just show up on the comment section? It's a product called Feminescence. It's at CVS, and it's a maca-based product, and it is something that, thanks, Joni. It's something that is, in my eyes, wonderful. It doesn't raise your estrogen level, but it can help balance hormones, and it can help you feel better, especially with things like hot flashes. Now at 24, the thing that you're going to want to look at, because you need estrogen for another 25 years, is your bone health, your bone density, things like testosterone, because your ovaries make 50% of your body's testosterone, your progesterone and your estrogen. So it's not just about the estrogen, and it's not just about hot flashes. I would seriously consider bioidentical hormone replacement for somebody that's 24, but that's just my own personal opinion. Angie, how long after histo do the ovaries die? I think Angie's worried about her ovaries dying right now. Angie, as you all know, is the whole reason, and I don't think any of you realize this, but Angie is literally the whole reason we're all here right now. She started the Essure Problems page just because of what happened to her. And to have this kind of an impact on humanity is just massive. And I want to just give her a shout out. And I mean, she changed my life, and I don't have Essure, but she changed the way that I practice medicine. So to think that you don't have that ability, and when I joined the Essure Problems page, I was pretty cynical about it, and she and the other Angie actually changed the way I think. So everybody shout out to Angie. But the average age of menopause, Angie, is about 51. So you still have some time. You probably have like 20 years left because you're only like, 30. But I think, if you think of the ovaries kind of pooping out instead of dying, because dying sounds so awful. If you think of them pooping out as a car's running out of gas and it starts to sputter, you probably start doing that. Some women start earlier, but perimenopause, 42, 45, that's when you probably are starting to notice that you're not feeling the way that you used to. And that would be when I would go in and look at some hormone replacement, or possibly doing hormone replacement. My coils were cut through during removal. I'm so sorry to hear that. I had an LAVH in November. My doctor has not discussed this with me or given me my photos from surgery. She told my boyfriend this and is in the operating notes. I'm going to let Angie Firmalino text you about this. I think you have something you can do, maybe talk to Holly, but you need to get an x-ray. Remember, your chart is your chart. The information in your chart is yours. The notes are yours. You should get copies of everything so that you can have them. An LAVH, there is absolutely no reason during an LAVH to cut the tubes. You can do a self-injectomy with the LAVH and leave the tubes attached. So I don't know why that was done. I wasn't there, but it's something to have maybe a second opinion on. And if you want to come out and bring me your records, I'd be more than happy to review those for you. After an LAVH, is it possible to have recurring yeast infections? Chastity, you can have recurring yeast infections without a hysterectomy. So, yeah, I mean, it's usually recurring yeast infections are due to just a vaginal pH issue. And it's more about just, bringing the pH down. You can use boric acid. You can use tea tree oil suppositories that you can get on Amazon. If you go on Amazon right now and type in tea tree oil suppositories, you can find them on there. We're coming on 30 minutes. Anybody got any more questions? How is I just had somebody say they were losing the feed. How is the connection for everybody? Is anybody losing connection? As you can see my son's face up in the thing right there. Great. Okay. Thanks, Tina. Any more questions? Did my comment come out on the feminescence? Because I can't tell if my comments are coming out or not. If I type something, are you all seeing it? And by the way, do you like this? Do you see this little thing? Like I just posted Karen's quote, feed is good here. Do you all see that? With Karen's beautiful picture. This is a new, oh, you're not seeing it. Huh. Well, that stinks. I've got this new program called, oh, you don't see my comment, but you're seeing when I post that. No, do not see your comment. So you see Joni's comment. Okay. So you're not seeing my comment. Okay. Well, that's something I'm going to have to figure out then, because if I comment, it says for some reason that's not going through. Okay. Any more questions before we wrap up? I've got 35 people on here. That's the most I've ever had. How awesome is this? So a couple of things that I put in the comments. One is the website to make an appointment with me, www.aaobgyn.com. Right on the front page of the website is make an appointment, book online, and then you click on my beautiful picture and you can make an appointment. The second thing that I talked about was Feminescence that you can buy at CVS. It's a maca-based product, and it works great for a lot of the symptoms. Karen's doing her Dutch testing today. Awesome. That's a urine test for hormone balance. It's an awesome test. Christina, are there any long-term problems after Essure removal? With regards to what? Most of what I've seen is people improve. I'm assuming you're asking, are there long-term, like are some of the problems you had before the coils are removed still lingering after the coils are removed? Cecilia, another one of our beautiful admins. Do you know if we have adverse events on your patients that have removal? Again, what would be your definition of, are you talking adverse events from the surgery or adverse events from having the coils in the first place? So if you can't find the Feminescence at CVS, I would go to Amazon, or I have a website that I don't usually talk about, but if you want to buy it for 30% off, you can go to www.npscript, like npscript.com/mind body dharma, DHARMA, dharma. And if you put in the code 4466, it will give you 30% off. So Christina, your question was, are I seeing adverse effects on toxicity? I've seen a couple of people for their 1-year follow-ups for their annual exams, and I still think women are feeling great. Most of the time I see women, it's at the 4 to 6 week visit, and they're still doing really well. The problem is if you remove the coils, and whether it's by hysterectomy or salpingectomy, are some of the problems that we were having. Like if you were having back pain before and you're still having back pain later, it could be because of your back, and it may not be from the coils, or coils could have been 50% of it. So that might be a little hard to, Cecilia want to know if I actually filed adverse events. Cecilia, I feel awful, but I haven't. And what I can do is I still have everybody's names on an Excel spreadsheet. I can certainly go through and file those if people want me to, that I've done their surgeries, but I have not. And, maybe in that area I've been a little bit delinquent, and I apologize for that. Isabella loves Amazon. I too love Amazon. Do most of the problems I see resolve after Essure removal? Yes. I wouldn't be doing these procedures if I wasn't seeing significant improvements. Angela, as you know, I was very skeptical 3 years ago when I first got on the page. Thankfully, y'all let me stay. But I do not cease to see amazing things with people getting better. From rashes getting better within hours to significant pain reduction, to headaches going away. I mean, it's crazy, but I constantly am seeing women get much better. Cecilia, I'll probably send emails out to my patients, and if they want me to do it, I'm going to do it. Angie Fermalino, use MedWatcher to file an AE. It's easy. Thank you, Angie. Will I join you at the ACOG rally in San Diego? I'm going to the rally in Austin, so if y'all want to come to Austin, I'll be here. And I'm going to do my best to, raise awareness. I don't know when the ACOG, I think it's in May, or it's May 6th, right? So I'm going to be here in Austin. What new complications do you see come from having the issue removed? Again, with regards to what? I'm not sure what you mean by new complications. I think the complications from having the issue removed are going to be from fragments left behind if it's not done properly. Can you speak about fluoroscopy during removal, when it's recommended, pros and cons? If Penny were here, she would argue this point with me. I don't do fluoro on everybody unless I'm not sure that I got all the coil. I can usually tell from looking at the specimen during the surgery where the coils are, and I have the x-ray. Patients that have fragments, I do fluoro on. I had one patient I did fluoro 18 times during the case because the coil was sewn into her vaginal cuff after her vaginal hysterectomy. So on certain cases, I think it definitely warranted. On the lady that has 5 coils, I would probably use it. The one lady that I did that had one up by her stomach, I would do it on her to make sure that I got it. And I would say that's probably 90% of cases. The pros of the fluoro are going to be that you got it all, obviously. The cons is that it's more radiation. And I guess that's the reason that I don't do it every time. If it was my wife or my daughter, I wouldn't want to expose her to the radiation if I really didn't feel like I needed to do it. If fragments are left behind, Mindy, that's the question. What does it do? We don't know. Is it the same as having a whole coil in there? I don't know if we know that. I can tell you from my experience talking to Angie and some of the others that have possible fragments or that have fragments, it doesn't feel good and you still have a lot of problems. If I told you I was going to chop up a paper clip and spread it around your body, inside your body, you probably wouldn't be too excited about that. So I think we have to look at that, and it's probably warrants some study, Stacy, you're welcome from Michigan. If we are post-histo, can we still have PET left in our body? That would be wreaking havoc, unexplainable symptoms. I suppose it's always possible, Karen, because I don't know. You can't see them. And technically, if you had a hysterectomy, I would think they would be gone. I mean, there's nowhere else for them to be other than in the uterus. So that's the one downside of a salpingectomy, is there's really no way to guarantee the PET fibers are removed. That's why I do the coring salpingectomy, because I'm trying not to leave any behind as the device is inserted. But with the hysterectomy, I would imagine we're getting them out. You're welcome, Julie. And you're welcome, Isabella. Have a good day. Have a good weekend. Angie, do you do a lot of corrective surgeries from botched Essure removals, and what are the problems? Angie, unfortunately, I'm seeing more of them. And to be perfectly honest, I think we're going to start seeing a lot more. And I think we're going to be seeing a lot more because more and more women are having them removed by well-meaning physicians who like I said earlier, think they can do a salpingectomy, which they can, but they don't have the respect and they don't have the desire to get all these coils out, and they don't have the knowledge base that I do. And the knowledge base that I have is, I'm not saying that I'm this genius person. I just have 250 cases to back it up on. But I do think that I'm going to start getting more and more of these surgeries where the turnout just wasn't very good. I think the two big surgeries that I'm seeing that get just not done appropriately. One is the vaginal hysterectomy, where the surgeon is just doing a straight vaginal hysterectomy and they're just cutting through the coils. Those coils are migrating. I've done 2 of those in the last couple of weeks, where there's fragments around the appendix and sewn into the vaginal cuff. The other is where they're doing laparoscopy and they're not removing them right. They're cutting the tube and they're pulling the coils, or they're cutting the coils right through the tube at the attachment to the uterus and leaving a fragment behind. Is it common to have many periods after hysterectomy? If you still have your cervix, it's possible. If you don't have your cervix, then that wouldn't be, I would probably go get that checked out. I can tell you from my own experience with having fragments, that you'll get the same issues, except if you've already had a hysterectomy. And I that's probably, Cecilia, what I would probably agree with is that if you have the inflammatory agent still in there, that you're probably still going to get some similar symptoms. Angie, will you be doing any medical journals or case studies? So what I'm doing right now, starting in February, next month, I'm going to the Society of Robotic Surgery conference, and I'm going to present a video, hopefully with the support of Intuitive, who is the maker of Da Vinci. I'm going to have try to do a dinner there for the doctors so I can present this as well outside of the conference. But I'm going to present the salpingectomy to show people how to do it. I'm also collating with Courtney and Natalie in my office are getting all of the cases, the data, the results, how patients feel. It takes a while because we're trying to collect numbers. Dr. Einarsson has 11 that he's done. I've done probably over 50 salpingectomies. So I'm gathering all that data, and I'm hoping to publish that just kind of as a report of what we're seeing and preoperatively and what we're seeing afterwards. So that's to come. I'm also coming up with a course online for physicians that is going to involve videos where they can learn how to do the procedure. It's going to have a PDF file so they can see my workup, my post-op, what to expect, what I do. And then also I'm hoping to have a website for physicians to go where we can talk privately about cases and we can just learn from each other and how to do things properly. So that's what I have in the works, and hopefully that will make an impact somewhere. What's the best way to remove the coils? My doctor recommended cutting and pulling. That would be the exact opposite thing you want to do. You can go back and watch the beginning of this talk, but I would go in and core the tube out, cut into the uterus, and remove it all in one piece. You don't ever want to pull on the coils. Angie, that's a good question. The hormonal imbalance issue, if I have women that come in that are post-op that feel great, they usually will ask me, do I need to keep taking the hormones? And I always say no. Hormones are usually for quality of life. And if you feel 100% better, then you don't need to take them. You're not going to take Excedrin if you don't have a headache. So some women stay on them. I would probably say it's about 50-50. Some women stay estrogen dominant, some reverse. But I think overall, women try to get off the hormones eventually. Nicole, I don't know if even me telling her is going to make her believe. I think my honest opinion is 5 years from now, this is all going to be something that just kind of like the mesh that nobody does anymore. And we'll be talking about it. And you can all thank Angie Firmolino for that. Well, initially, now she's got a whole bunch of admin that are helping her too, but she's the one that started this whole movement. At 31, should you leave your ovaries? That's a personal choice. I don't think anybody can answer that for you except you. Again, 1 in 70 risk of ovarian cancer, not too high. They're going to work on you for another 20 years, so they're going to balance your hormones as best as they can. If you have them removed, you're probably going to, feel poorly and want to talk about having hormone replacement therapy. So I'm going to stay on for about 15 more minutes. We're still getting more and more people. So if you still have questions, feel free to shoot them out. I think any question you ask is going to help. If the last video I did is now at 10,000 views. So obviously this is being viewed all over the world, and you're helping anybody with your questions. So how do I make sure my doctor knows how to safely remove the coils? Wow, that's a loaded question. I guess you could show them the videos. You could have them call me. You can have them email me. Dr. Dr. Tassone, Tassone at AAOBGYN.com. I'd be more than happy to talk to them on the phone if they wanted to talk to me. They can watch these videos, or they can sign up for my course, and I'd be more than happy. The other thing I'm trying to do with the course is, if physicians take the course and feel comfortable removing things, I'm going to try to have a website where you can go put in your zip code and find somebody in your area that I think is good at it. Because what I'm seeing now is just this question right there is, you don't know. And the doctors aren't going to tell you it's rare that you're going to see a doctor say, I have never done it before, but I'm willing to try. Usually they're going to say, yeah, I've done a few of them and I'm doing pretty good at it. So it's hard to know. Seeing high cardiac issues, or do I see high cardiac issues? So, Laura, if you're worried about it, one thing is you can always cancel. You don't have to do it. It's not life or death. It may feel like it is, but it's not. So you can always take your time and, make sure you're doing the right thing. But, go to your state Essure website. Make sure your doctor you're comfortable, because that's the main thing, is you want to be comfortable with who's operating on you. That's what I would recommend. What are the risks for removal with more than one coil in a tube? Lisa, actually, if they're both in the tube, it's not a big deal. It's when they're not in the tube that makes it a little bit harder, because you have to find out where they are. So if the Essures are both in the tube, it's exactly the same. It shouldn't add much to the surgery. What I have found has been particularly difficult is when you're doing just a salpingectomy and removing the coil, and the coil was put in poorly, so the part that's in the uterus is all bunched up and it's like a knuckle. It's much harder to get that out, and you actually have to make a wider incision around the uterus to get that out. My hair is falling out. That's horrible. I don't have FMLA available until July. What can I do just to help my hair grow back till I can get to you? It depends. Hair loss is usually stress related. And I don't mean that like it's in your head, no pun intended. But I mean that sometimes the issues that you're having can make you so stressed that your hair falls out. It can also be an allergic reaction. It can be many things. I have found that a lot of the times, if you remember back to your pregnancy, you had good hair, and after you were pregnant, your hair started falling out. Progesterone tends to help your hair stay kind of status quo so that it doesn't keep falling out. So that's one thing you can do. It could be a blood flow issue, so they do have Rogaine over the counter for women. You can try that. But I would consider seeing a dermatologist and see what they say. Maybe they would consider doing some allergy testing. Wait, we've got someone here from Northern Ireland. What time is it in Northern Ireland? This is a new procedure here. I have headaches since having them put in. I've also gained over 10 pounds. I see that in almost everybody. You ladies chime in. Weight gain and headaches, really common. It's really common in the general population as well, but it seems to be pretty common in the Essure population. Mayo said if ovaries are removed, they have seen an increase in cardiac issues, including death. What that means, and this is, I don't know exactly what you're referencing, Kim, but if women have their ovaries removed and they don't go on hormones and they become menopausal, their heart attack risks are going to increase to the level of a man's, because estrogen is actually cardioprotective and can help with your cholesterol levels and your HDL. So yeah, if you have your hormones removed from you and you don't have them replaced, that can increase your cardiac issues. Hubby says it was put in incorrectly. He watched the procedure. I had a misfire and the doctor shoved in. Well, shoving is kind of a description, but technically they're all shoved in. I mean, that's the only way we can get them in is to, I could say gently slide, but it's a shove. And since he's only seen the one that you had done, it's really hard to quantify that for him because he's never seen it before. But, you know, sometimes you will get a difficult insertion. I will definitely agree with that. Stacy, what do you think caused us women to smell so bad with Essure? Oh my gosh, like death or rotting during bleeding. I have no idea. The only thing that I can think that would change odor would be bacteria. Well, there's a lot of things, but bacterial vaginosis is fairly common, especially if you have a lot of bleeding, because you're changing the pH of your vagina to a more alkaline environment. And when it's more alkaline, you can switch over to bacteria like E. coli and Gardnerella, which have a pretty foul odor. So you might need to see your doctor for that. And that's exactly what Christina just said, because she has experience. And, you know, I think like a lot of these questions are, there's a lot of wonderful resources on this page. And again, the admins do a great job, even if they don't post all of my posts, because some of them have Christmas pictures and stuff. I get it. I'm just kidding. But what other questions do you guys have before we're getting on an hour? That went by so fast. I just, you know, honestly, I wanted to do this because I'm just tired of seeing all the incorrect surgeries being done. And I really want you guys to ask questions. Chemical metal combinations. The only time I had a smell was when I ate fish. Possible. Lisa, the tube spasmed. I didn't do any pain meds. Was painful the second time. And tubal spasms are very common during insertion. Angie, recurrent BV. Oh, it's the bane of your existence. It's the bane of any gynecologist's existence because it's a pain in the butt. Recurrent BV is basically a problem with the ecosystem. It's a problem with pH. And what I do with women that have recurrent BV, and I'm just going to talk about what I do with my patients, is for the first 5 days after their cycle stops, I put them on boric acid capsules. And I have them put 1 capsule a day in their vagina for 5 days. This brings that pH down to a more acidic level. Then I have them repopulate the vagina after that for 3 days with vaginal probiotic suppositories. I also then have them buy the tea tree oil suppositories to self-treat in between, so we don't have to keep using antibiotics. To use the tea tree oil suppositories to treat BV if they feel like they have symptoms coming on. Usually, if you do that for about 3 months, things kind of correct themselves. Some women have such a fragile ecosystem that they have to use like a boric acid capsule after intercourse because semen is alkaline, or they're using condoms and the spermicide is alkaline. So everybody's a little bit different, but that's kind of how I treat that. The Essure has caused me to have black bleeding for up to 8 days with black mucus after the period is over. He insisted on a biopsy. I do not do reversals. Eric Sills does reversals. Monteith does reversals in North Carolina. I'm not sure if Daron does them in Atlanta, but there's other doctors in the group that do those. Karen, if you get overwhelmed with the supplements, I can't tell you how many I take a day, and it gets confusing for me too. And I agree with you. It can totally be simplified. Supplements also are just a piece of the puzzle. They're not, the cure-all, end-all. They just are there to supplement. So if you need help with that, just let me know. Michelle, you're very welcome. Numb extremity happens on and off. I would probably go to your doctor and let them evaluate you, or go to a chiropractor or somebody that has more of an idea about nerves and possibly slip discs or issues going on with the spine. I would definitely get that checked out. If the coils were cut through during surgery, you need an x-ray. Pure and simple, easy enough. And then go to somebody that knows how to remove the fragments, if there's fragments there. What is the best way to get more doctors on board with removals? I live in Ohio, and I know that there are doctors that do removals, but none close. Misty, I don't know. You could probably ask Angie this, but doctors really need to come to this on their own. And whether that's from just patients doing this, I know that the general consensus still is probably that y'all are crazy and that Essure doesn't cause problems, but you can feel it shifting. It's shifting a little bit. I don't think there's probably as many procedures being done as there used to be 10, 12 years ago, for sure. And I think it's just, talking about it and just being open about it and making sure that people know what's going on. What imaging is needed for proper location prior to removal? Two things you could do. One is just a flat plate and upright of the abdomen and pelvis. It's just an x-ray. What that will tell you is where they are, in the sense of, are they in your pelvis, are they in your abdomen? It won't give you the grade, and it won't give you, where in the tube they are per se, because you can't see the soft tissues on an x-ray. If you want to know exactly where they are in relation to the uterus, you get what's called a hysterosalpingogram. The reason that I don't get hysterosalpingograms on everybody is because a lot of people have histories of ablations, so an HST won't work and it hurts. But secondarily, again, it's a pretty good dose of radiation that I don't think you necessarily need to have. So Sherry, the bladder lift thing is a good question. If women in this group want or need a bladder suspension, or if they need something done because they're having incontinence, I don't do mesh for those patients because I know they don't want foreign materials in their body, and that makes complete sense. The mesh lawsuits did not include slings. I think the slings, if they're done by a person that knows what they're doing, has a place and can help people. But if it's not done correctly, and if it's not done by somebody that knows what they're doing, it can cause harm. So again, it needs to be done by somebody that knows what they're doing. And again, it needs to be done in the right patient. Caitlin, you're welcome. She feels great. Still some bleeding at times, but not as bad. Good to hear that. Glad you're doing better. I had one coil removed and the coil is in there. I had two questions. Am I able to get pregnant, and how can I get the other coil out? So the only way to know if you can get pregnant is to have a hysterosalpingogram to see if your tube is open. And then two, if you want the other coil out, you need to see a doctor that knows how to do coil removal. So we're at an hour. I think it's probably time that we, wrap up. We've got some people that have left already, so I don't want to bore everybody to tears. And, as time progresses and we get a little bit farther into this and I start seeing more things, I'll definitely do this more often. I want to thank you guys for coming. I want to thank all the women that have taken the time to come see me. And I really appreciate your trust. This has been a growing experience for me as much as it has been for y'all. And I have a feeling that in the next 1 to 2 years, this ride is going to get bumpier. and it's going to get crazier. And I think we're going to make an impact. So thank you guys, and have a great weekend. Enjoy your weekend. And if you have questions, let me know online.